Thank you for that. And haven't I already told you not to hype it up too much? It's under promise and over deliver. Okay, so want to talk about clinical practice guidelines and a little bit of background and just a little bit of why I'm doing this. As many of you know, I've been teaching things related to evidence-based medicine in our residency program since even before I was an APD. And in the early days, we spent a lot of time talking about meta-analysis and systematic reviews. And to a great extent, a lot of that has kind of fallen by the wayside, I think, in no small part because so much is done by clinical practice guidelines. And as we've gotten more and more into clinical practice guidelines, it's really, I think, another set of skills and a little bit of art and a little bit of science, and really understanding how these impact the way you take care of patients and how you should think about them. But as usual, some disclosures. There's not a whole lot of money to be made in teaching about clinical guidelines, so I don't get anything. But let's frame this with thinking about a case from primary care. And as we talk about clinical guidelines, I want you to keep in mind the idea of this case, because we're going to be talking about some clinical practice guidelines that might impact your care of this patient. And so this is your patient, Chris Talon-Toe, is a 54-year-old man with a history of prediabetes, hyperlipidemia. You've followed him in your clinic for several years. 2 years ago, he had his first episode of red hot and tender first M2P joint. You diagnosed him appropriately with gout and treated him with NSAIDs, and he got better. Over the next 16 months, he had 3 additional acute flares of monoarticular arthritis. And although you weren't able to get it on the first day, you finally got a joint space big enough and did an arthrocentesis, and indeed showed that he had urate crystals. Serum uric acid at some point early on in this was 8.2 milligrams per deciliter. On examination, he has no tophaceous deposits. His creatinine is normal, as is his estimated GFR. You started him after these multiple events on allopurinol and eventually titrated up his dose, started him at 100 and titrated up to 200 milligrams. And over the past 9 months, he has had no flares of gouty attacks. He's doing very well. And other than that, he's mostly just in for routine healthcare maintenance type of things and just checkup. So the question that I want you to keep in mind is this: should we check his serum uric acid level at today's visit? Okay, again, so on allopurinol, no recent gouty attacks. What does the evidence say? What should we do in terms of monitoring and measuring his serum uric acid level? And so that we're going to launch a poll, just because I want to sort of see what people say about this before we even think about the evidence. John's poll, yes. And this isn't mix-up. I'm not actually looking for a single right answer. I'm actually wanting to see if we move the bar as we go along with this morning. So in other words, low stakes. I'm not going to pick on you for picking one or the other right now.
I feel like every one of your polls is a high stakes poll, though. Just joking.
Mac, with you, it might be. Cool. Okay. Yeah, interesting. I kind of had expected that it might have been flip-flop, but I see that so 38% said yes, they would check in, 62% said no. Okay, so I'm gonna just make a note of that because I want to sort of see how that changes over time. Okay. So as you want to sort of think about his care, you go and do a quick PubMed search. You even look on UpToDate and see that there's at least 6 different clinical practice guidelines related to gout management. And some of them are from places that you haven't heard of. This European League Against Rheumatism, maybe some of you have heard of it, but I hadn't. The Dutch College of General Practitioners, the Japanese Society, and the British Society for Rheumatism. Rheumatism, such a great old-fashioned word. I love that. But you also find that there are two US-based recommendations, guidelines. And the first comes from 2012 and is from the American College of Rheumatology. And a second one is from 2017, is from the American College of Physicians, the ACP. And these two guidelines, you'll be getting a chance to get your hands on one of the two guidelines in a little bit. But these two guidelines, published again 2012, 2017, both had to do with the management. And I picked these partly because they actually ask in each of these this very question about should you be checking serum urate levels and monitoring. Okay, so with that, let me just ask the group, either shout it out or throw it into chat. What are some of the reasons that you use guidelines? What are some of the things, why do you reach for clinical guidelines? And again, there's obviously not a right or wrong answer. This is purely from just being curious. What are you guys thinking about when you reach for guidelines? Because I don't know what
I
to do.
I guess I think of guidelines like, and I when I talk with medical students about using them, is about finding the general direction that the field is thinking that should be pursued, and then also I look for the direction that I should not go, because I feel like I really trusted the direction that I should not go based off of guidelines, versus I think it's a much wider, um I don't know, there's less consensus on like the absolute answer for a lot of things.
Yeah. I think there's a lot in there. Some of that I think is in the chat in terms of some other very similar overlapping ideas, ranging from to see what people smarter than I do, which is selling yourself short. To find consensus recommendations, Adrian, we'll talk about what consensus actually means. To standardize care, Lily, we trust that someone else had the time. Okay, so Wes, to that, clinical guidelines versus up to date. Do you have, because both of them will do that, do you have a sense of why you might want to favor clinical guidelines versus looking at up to date? Your microphone, I don't think I caught what you said, but I'm looking at a lot of other great ideas in here. Lily, making sure my biases aren't affecting care. Also, when I'm less up to date on the literature, I'm never up to date. Okay, they're usually very close to the same. We'll talk a little bit about up to date versus clinical practice guidelines and how they're similar and how they're different. But let me show this. Let's even get more basic. What is a clinical practice guideline anyways? We're talking a lot about it, but is there actually consensus of what a clinical practice guideline is? Is a clinical practice guideline simply anything where someone tells you what to do? So where someone else is telling you what to do? Is that a clinical practice guideline? And preferably it's like a big old list that's easy to read bullets and some makes it easy to find it. Is that what a clinical practice guideline is? Or actually, is it something deeper than that? Is it something more than that? Is there something that makes it an official clinical practice guideline? We're going to jump right into it in a sec, but as I'm doing so, does anyone have any thoughts about what makes something a clinical practice guideline versus just an opinion? Like, what is it that has to be there in order for us to really feel confident that it's doing what we think it's doing? Expert consensus based on existing body of evidence, grading of recommendations. Great, Adrian, we're going to come back to that. Something released by professional association that's based in the literature. Lauren, I appreciate that you said that, because that I think is a really important part of it, and we're going to come back to that. An appraisal of evidence, level of evidence. Yeah, all of those I think are really great points. What I want you to think about is this question about why is something a clinical practice guideline versus a systematic review or a meta-analysis? Like, what is it that makes it that instead of just a systematic review? Okay, so we'll come back to these things. So there's a lot of, it's a little bit of like this thing about like, I know it when I see it, right? It's a lot of people think that they know what it is, but then when you try to put it down on paper, it proves to be a little bit slippery and hard to actually describe. But in 2011, the Institute of Medicine, the IOM, tried to wrap their arms around this whole burgeoning clinical guideline field and said, describe clinical guidelines as statements that include recommendations intended to optimize patient care that are informed by a systematic review of evidence and assessment of the benefits and harms of alternate care options. The definition is a lot longer than this, but this is sort of the essential sentence in their description. And so, so in here is, again, that it's meant to assist practitioners and patients. It is evidence-based. Recommendations are evidence-based, not just opinion. And this is one of the distinctions I would make between this and a chapter in Up to Date, because although Up to Date will cover a lot of evidence, they're not necessarily doing it in an explicit evidence-based way. Where are we here? And that there's a weighing of the benefits and the harms. And so, dynamite for the win, thanks. But again, this question about like, well, all of that is true, all that's great. But again, why is it different from a systematic review or a meta-analysis? Many times, many of you have heard me talk about systematic reviews or meta-analyses, or if I haven't, we'll talk a little bit more about them in a bit. But those are good, we like those. This hierarchy of evidence idea, which is sometimes a little bit of a problematic representation, but every one of us probably in medical school had some sort of presentation about evidence-based medicine that presented something like this. And it's this idea that at the bottom of this evidence pyramid, there is expert opinion and just people spouting off. And then case reports are probably the next, where you start to see a signal, and then observational studies such as case controlled cohort studies are have some risk for confounding and residual confounding and bias, but we then favor randomized control trials, and then we think about systematic reviews and meta-analysis. And it's built like this pyramid with this idea that as we get closer to the top, that somehow the information is purer or better or more refined. There's a lot of problems with that idea, but that's at least behind the idea of an evidence-based pyramid. So one of the things, I think it was Lauren who said this, one of the things that is different about a clinical practice guideline is that there is usually, if not always, an endorsement by a sponsoring group. So some group or some organization has put their imprint on it and said that we sponsor this, we support this, and therefore this clinical practice guideline is not just a couple of researchers saying this, but actually it is the Society for X, Y, or Z that is supporting this. Okay. In addition, and this is a little controversial, but I hope that I'll convince you of this. There is an increased role for expert opinion within the formulation and construction of clinical practice guidelines. We'll come back to this in the second half and what I mean by that exactly, but I want you to keep in mind that although we place them at the top, in some ways in the way we act, we think about clinical practice guidelines as if we use them all the time in our everyday practice, but maybe actually it's messier than we think it is. And so I want you to sort of have that idea in mind as we think about this. Okay, so how many clinical practice guidelines are out there? I literally could not find the answer to this question. And the reason I couldn't find the answer to this question is because, well, I'll come back to why we can't find the answer to this question, but just a few statistics. So in 2008, some group counted and found that there were about 722 clinical practice guidelines that were added to the literature that year. How they did it, I don't know exactly. 2011, at the time of this IOM report, in their background, they reported around 3,700 clinical practice guidelines that they could find. By 2017, there is this international group that is warehousing clinical practice guidelines, keeping track of them and keeping them online there. And they had about 6,200. And there is a database in the US, so AHRQ, which is Agency for Healthcare Research and Quality. It's an agency that does a lot of health services related things. They had a data warehouse, and they had about 2,000 at that point in time. When I looked yesterday, I did a PubMed query and I used mesh terms. And so I was trying to do the best way I could search this. And I found 30,000 citations. Now, I don't think that those 30,000 citations are clearly all clinical practice guidelines by the way that we're defining this. And I think that's part of the problem. Again, there's not necessarily a standard common definition for what someone calls a clinical practice guideline. So somewhere between 30,000 and then probably like 10,000. The AHRQ database that I mentioned was the funding for it was cut, and so it's no longer active during the prior administration. You may realize they had different priorities than the current administration. And when I counted yesterday, I went through the USPSTF, US Preventive Service Task Force, the American College of Physicians, IDSA, ACC, just to take a few that I commonly use. I didn't even include things like chest guidelines or anything like that. And I counted 251. Not all of them were active. Some of them had been warehoused because they were considered too old and no longer up to date. But that gives you a sense of just these 4 organizations alone, you're already into the several hundred. And so I don't know how many clinical practice guidelines there are. So there's a whole lot. No one knows for sure. And again, the definitions are really, really slippery in all of the stuff. And that's probably a lot of the reason why it's so hard to count them. All right. So what do you do when you get a clinical practice guideline? I mean, you've probably tried to pick up some of them. I mean, the chest guidelines for, thromboembolism is like, I don't know, it's like 100 pages or something huge. It's really a lot of information. And you may be like this person who's sitting there like, oh my God, it's too long. I just tell me what to do. And, you know, that's okay. That's not entirely wrong. So I think that the way I think about this is I'm going to give you sort of the quick and dirty. So like if you're on the wards, if you're in the middle of a busy clinic afternoon, here's what I do in terms of reading clinical guidelines if I'm going to pick one up. And I think it's reasonable. So pick a guideline or set of guidelines from an organization that you've heard of and trust. So don't pick one from an organization that you've never heard of. The ones that I mentioned, American College of Cardiology, you know, things like IDSA, US Preventive Service Task Force, those organizations, the size of the organizations and their membership and the fact that there are a lot of people watching what they do means that they spend a lot of time and effort vetting and making sure that the clinical practice guidelines are reasonable. So I think that that's the first check against falling into the trap of finding a bad clinical guideline. All right. But at the same time, if you pick an organization's clinical practice guideline, I would try to keep in mind a little bit the philosophical leanings of what that group's about, right? If you pick up a clinical practice guideline from the US Preventive Services Task Force, you should know that they have a different orientation, and I'll show you an example, than another organization that might be a patient advocacy first organization. Right, so their orientation might be different from the American Cancer Society, which is predominantly an advocacy organization for patients living with cancer. So their view might be different from their the American Cancer Society's point of view. And then what I think you should do is oftentimes, again, these are very long, look in the index or whatever, find the bulleted recommendations in the text, use your search function in your browser or whatever, find the bulleted recommendations for that one part that you're looking for, or the table that represents it all. And then once you get to that part of that section, take a couple moments, look at how they represented the strength of the evidence, the magnitude of benefit, and the certainty of the evidence. A good clinical practice guideline should tell you a little bit, whether it's in words, in text, or with a code, like a letter code or a number code or something like that. It should tell you something about what they think about the strength of that guideline. And so this is from US Preventive Services Task Force, and many of you, most of you hopefully, have spent some time looking at the USPSTF guidelines. And so this is, I just picked randomly AAA screening for men who'd ever smoked. And AAA screening, sorry, this also includes men who never smoked and women who have smoked. And so the USPSTF grades, letter grades, so it's a lot like grades from school, so A, B, C, D, and then I, which is inconclusive or not sure. So A and B are considered higher grade evidence. C is where there's, not clear benefit, and D is potentially certainly no benefit, but also harm. So that's the way USPSTF grades their information. I was talking about the philosophy of the group. USPSTF tends to be extraordinarily conservative about its recommendations. They are very, very rigorous in terms of what they want for the quality of evidence, and they don't give their stamp of approval unless there's pretty good evidence about it. So you're not going to get borderline things. You're not going to get filling in the cracks with, okay, there's not information there, but um, we will we'll throw expert opinion in there or something like that. Jordan, I don't know the answer to that. I hadn't actually been aware of that, but let me look into that question. Okay. American College of Cardiology, so ACC, we often talked about GDMT, right? Like all I hear these days is GDMT, GDMT, GDMT. It's like, it's this mantra. They're at GDMT. And so just out of curiosity, as we're talking about guidelines, I was like, gosh, what does it say? What do their guidelines actually say about GDMT? And so among other things, here's one of their recommendations. So it says GDMT, and this is specifically around how you prescribe goal-directed medical therapy for patients with heart failure and how quickly you uptitrate. And, so it's very easy to read. It's very color coordinated. They divide things by what's called COR, which is the class or strength of the recommendation, and LOE, which is the level or quality of the evidence. And so their top recommendation here says in patients with heart failure with HFrEF, titration of this is good. It reduces cardiovascular mortality and hospitalization unless the patient has side effects. And their level of evidence is very high in terms of the strength of evidence as well as the quality of that evidence. But interestingly, look at this next one here, which is you probably have seen people talk about, like, we're going to just every 1 or 2 weeks, we're going to bring them back. We're going to put on these things. And if you look at this and you read the fine print, it's level 2A, which they call moderate recommendation. And when you look to see what it's based on, it's this abbreviation C-EO, which is level C. So it's like not A, not B, but it's level C. And it's based on expert opinion, not on clinical trials or specific research data. So this recommendation, again, it's in a clinical practice guideline. You may see and have many of your patients actually getting rapid titration up of their medications, but it's based on sort of middle class evidence and mostly expert opinion. So again, not bad, but I think as we think about why and how we use clinical practice guidelines, I want you to think about like that actually there's a lot of squishiness to it that is hidden under sort of this very shiny veneer of clinical practice guideline. All right, we'll definitely come back to that idea. All right, what if you have more time? What if you've actually got the chance to dig deep and you can look at the clinical practice guideline in a little more depth than just the table or figure? Okay. There are checklists that are published and are out there. And so one of the ones that is widely used is the one from that Institute of Medicine report from 2011. And I've pulled from it and I've taken a couple of high points in here. Sarah, if you don't mind putting in the chat the link to the handout. I've written this in a handout form on a Word document. And so if you download this, if it works best if you have Microsoft Word on your computer. It doesn't show up right if you do it on your phone or something like that. But you'll see if you download it, you'll see that it's a checklist, and you can literally, because of the way I set it up, you can check it, and there's boxes where you can enter text and notes to yourself and all that sort of stuff. But here are sort of the highlights of what I put into that, and this is from the Institute of Medicine guidelines. So first question is, who wrote the guidelines? All right, or a series of questions. Who were the people at the table? How are the committees chosen? How are panel members chosen? Was there a multidisciplinary panel, or were they mostly subspecialists, or were they generalists? What kind of points of view from a clinical perspective were represented? Did they have people who are methods experts, so people who are actually like statisticians or people who are expert in terms of understanding the research. Was there, and this is, I think, we increasingly recognize the shortcomings of a lot of practice guidelines when we weren't doing this. Is there actual representation from the groups that are affected by the guidelines? Who's at the table in terms of the patients? Was there a chance for an external review? So was there a peer review? Was there a public comment period? Who had the final say? Who got to prove whether the guidelines were official for that organization? And importantly, how are financial and non-financial conflicts of interests handled? You'll see a lot, particularly in some of the subspecialty guidelines, you'll see pages and pages of potential conflicts of interest. What did they do with that? What happened if people had some significant conflicts of interest? Did they still get to vote on those clinical practice guidelines if there was a possibility that they might actually somehow gain benefit from it? So important things to think about. So who wrote them and who was at the table? Okay. Then think a little bit about how the guidelines were written. And because there's not really necessarily a single standard way in which guidelines have to be done, I think that the most important part for you is to really see that they were explicit about the methods and processes. So in broad daylight, did they actually share how they went about their decision making and how they voted and how they decided whether something was recommended or not? Did they have these clinical questions predetermined, or that's what you would ideally want, or did they go on a fishing expedition after they went through a lot of stuff and then come up with the questions later? That's a little worrisome that they're doing a they're looking to fill their data instead of starting with the question in mind. Were they transparent in the process to minimize the bias, distortions, and those conflicts of interest? Was there a rigorous systematic, I meant to say not systemic, systematic evidence review that not only synthesized all the results, but considered how the quality and quantity and consistency of those results were? And did they create for you a way to look at this? Did they rate and share the rating of the strength of the recommendation and the quality and level of evidence? So were those visible to you, and can you find those in their methods? Um, and then the final group of questions is, how do you apply this to the guidelines? So were the recommendations all equally well supported, or is some of them less certain because of conflicting or lack of evidence? Were they ultimately appropriate to what supporting evidence they showed you? So did they make the appropriate step from what they saw in the evidence, or did they make a leap further than you think that the evidence actually supported? Was it clear when the data was collected and how current the evidence is? So in other words, is this all data from 10 years ago? Does it include data more recently? And what is the mechanism they have in place for revising the guidelines as new data arrives? So the examples that we're going to go over are from 2012 and 2017. So that's a lifetime in some cases. That's a lot of time to pass. Like, is there actually new information that's come out since then? And what do we do with that new information? And what's their mechanism for dealing with new information? So again, the link that Sarah had in the chat will take you to this document. And again, you can check through this as you go through and as you look at this, as you read the clinical practice guideline. And so you can have a list and make some comments to yourself, and you're welcome to it so that you don't have to sit there and look up the Institute of Medicine guidelines every single time or have to remember it. Okay, so let's go back to our case that we started off from primary care again. So this is your patient who has proven gout. He had previously a lot of attacks, and since being on allopurinol, he hasn't had any in the last 9 months. So the question again was, should we check his serum uric acid level at today's visit? And about 38% of you said yes, and 62% said no. All right. The question ultimately in this is, not only should we check it, but really, should we check the uric acid level to use it to adjust the treatment? So do you need to titrate the allopurinol based on what the uric acid level is going to be? And are you kind of treating to target? You're treating to target number of the uric acid level. All right. So with that, we're going to place you, with Javel's help, into breakout groups. You're going to be in groups of 8. Oh, sorry. Sarah, do you mind putting the 2 articles in the chat as well?
Yes, I can do it right.
Thank you. The two, we won't put you in the breakout groups quite yet. We'll give you a second to orient, but the groups will be groups of 8, so there'll be 4 groups and 4 groups. Groups 1 through 4 will be reading the 2017 ACP guidelines. So it's the first one that Sarah's put up there. The groups 5 through 8 are going to be reading the 2012 American College of Rheumatology guidelines. Now, these are really long, and I've included a lot of supplemental information in them. So I've attached together like the supplements that go along with it or the separate methods paper. I have no expectation that in the next 20 minutes or so that you're going to be able to go through all of that. But what I've done for you in each of these articles is I took a highlighter and highlighted some passages so that if you want to kind of focus your attention on some of those, I think that the answers to many of these questions will be in some of what I've highlighted for you. So that way you can shortcut and just go right to the questions, all right? In addition to the question itself and getting the answer that the guideline is suggesting in terms of the recommendation, I really want you to spend a little time getting a flavor for the methods, because, spoiler alert, the 2 guidelines differ on their recommendations on this. And in the second half, we're going to talk about why that is, or why that might be, and why it is that people look at the same information and come up with different answers. And a lot of it comes down to differences in the methods. So if you can, spend a little more time than you might otherwise. Don't get too bogged down. Try to keep the focus and keep the flow going. But you'll have 20 minutes when we break out into the groups. When we return, I'm going to ask a representative from each of your groups to speak up about what your group discussed. And so one thing that you might do is one of you might put on your screen that checklist or the article, and then together, as you discuss, you might just go through the checklist. And so as a reminder, again, groups 1 through 4 is going to be the ACP article, groups 5 through 8 are going to be the ACR articles. And so that, Javel, if you're able to, let's go ahead and put them into groups 1 through 8.
Okay, final reminder, click those links that Sarah put in the chat.
Yeah, otherwise you won't be able to. Yeah, we'll give you a sec before you go into the room, grab the article.
Yeah. Right, you'll want to download both of them because you don't know yet which room you're in.
Oh, sorry. Thought I was being so clever.
Okay, 20 minutes. Starting now. Okay.
Have a chance to say to everyone, I don't, obviously don't worry if you didn't get through all the questions. It was really an exercise about what it feels like to try to find the information and what it is like to try to search for those kind of things. I'm curious, before getting into specifics, any impressions, any comments of what it felt like and what the exercise was like for all of you?
Yeah, I have thoughts about this. I think it's
Really, John? You have thoughts about something?
I've got strong thoughts about this. Strong recommendations, actually. I think it's great that we have, these task force and individuals that come together and really sift through data. But I also find it just ridiculous the amount of pages that you have to go through just to get a simple answer. Like IDSA guidelines. Like I personally think it's stupid, and I think it's that we just need a box of something saying you should do this or you should not do this, and then to have it that simple. And then if you want to continue to read the rest of the stuff, great. But who has this much time for every patient if they have a clinical question to sift through pages and pages of recommendations?
Good. But really, tell us what you really think. I love this Chat GPT. Yeah, probably very soon, right?
I totally hear you and I agree with that. And I also think like that's the point that like these guidelines are actually a lot more nuanced than like what can be just uh like distilled down to a box or a sentence. Because there are a lot of things that go into it, and some of these things kind of counter each other, and like it. So I wonder if like there could be a little bit of both, because like I would never read any of this if it was just like one sentence. I would never like go through the efforts to like actually look at how nuanced everything is, when really in reality it is all very nuanced.
I think it all has to deal too with like how things are formatted, how things are presented. If you look at like the KDIGO guidelines for so many of the different things in nephrology literature, they have a very like great format that is like bolded, bulleted, all these different things. Then they walk through like your initial scroll for the first few pages, like being able to see stuff, like the actual breakdown. And then when you want to, like, you can click the link to get to that spot. It has the bolded recommendation right there and then some more information. I found that just how something is like arranged visually, it makes it easier for me. I think my comment pivoting away from this we were talking about like the disclosures and finding out funding sources and stuff like that. We couldn't really find it like in the supplement that they said that they provided and all these different things until we found, I just searched like funding and disclosures, and then they have like another page which goes to like you have to have internet access to get to that, and then you have to download another PDF, and then you have to scroll through this very large document of a lot of kind of bureaucratic mess to actually figure out where people are getting funding sources from. So I'm not sure if that's the common thing to do, but it was a little frustrating.
Yeah, but I think that's the tension, right? I mean, you're sort of talking about both sides of this. There's the transparency and how easy or hard it is to find the information
Yeah.
about things like disclosures, and yet it makes it busy and it makes it really crowded and makes it hard to read and all that sort of stuff. The that's exactly right. I think that I'm going to pick on the cardiologist. Sorry for the cardiologists in the group, but gosh darn, that
Don't be sorry for
document
them.
about the heart failure is so long, and it's just like I can't find anything, right? But so it's a tension. The ACP version, those of you who had the ACP article, you'll see that I included actually 3 articles. So there's the clinical guide, the guidelines, which is relatively short, and they keep referencing all this other stuff. And then they have the systematic review, which is longer. And then they have this other thing that they talk about. And basically, here's our methods. So that's one way to do it. They try to make it simple, but then if you really want to get into it, then you got to pull up 3 articles, not just one. So it's hard. They always have a slide set of version of the guidelines. Okay. We need an Occam for clinical practice guidelines. It's so meta, right? Like we need a set of guidelines for guidelines. And in fact, there is a set of guidelines for guidelines. We'll talk about that. Okay. So someone in the ACP thing, what did your guideline recommend? So in your patient with gout on allopurinol, would you check serum uric acid level to see if below 6? Someone from the first half with the ACP ones, tell us what their guidelines suggested. And
sounds like the data for that was insufficient. There was, I think, 1 or 2 studies that showed that patients with like a urate level less than 6 had lower rates of recurrent gout attacks, but that there were too many factors that couldn't be accounted for, like lifestyle changes that may be playing a role. And then I think they overall concluded that a lot of that was just observational data.
yeah, so in short, couldn't recommend insufficient data to recommend it, right? Is sort of what they said. How about for the
I'm sorry.
No, go ahead.
I was just gonna say, like it said, like you could, decide on like a patient by patient basis, but yeah.
Yeah, the dreaded shared decision making, we can't say one way or another. Yeah. Is that the final common pathway for all of these things? It might be. What about for the American College of Rheumatology? What did your paper say? Someone in groups 5 through 8.
So American College of Rheumatology, from what I could see in the text, did recommend targeting uric acid level below 6, and they said that there was level A evidence for this, which means more than one randomized clinical trial.
Yeah. How do people take the same information and interpret like completely differently? We'll get to that. Just for my curiosity, I'm going to run the poll again if we could. And now that you've had a chance to look at your particular group's recommendations, I'm curious if anyone's going to change their mind. Like, let's see what the group says. So tell me, are you going to check uric acid level? Oh, this is interesting. We'll give it another few seconds. Lily, you've been hanging out with me too much. Yeah. So we hardly move the bar one way or another. We said 38% last time, now we say 34%. So I think that's probably the difference of like 1 or 2 people or something like that. So not much change even after all that time spent looking at that. All right. Let's see here. So is anyone willing to say that they changed their vote based on the guideline that they read?
Yes, I'm willing to say. I read the ACP guidelines, and their appraisal was that there was insufficient evidence to compare treating to a uric acid goal versus clinical outcomes.
So you had been inclined to test, and now after reading that, you're inclined not to test. Is that right?
That's correct.
Okay, cool. Thank you for saying that. Did anyone go the other direction? Anyone who wasn't going to decide that they were going to based on the ACR guidelines?
John Goodman, did you change your thoughts?
Mac, is your role to just like sit there and goad? Is that
A little bit. I'm just
okay?
trying to make things a little spicy. I promise I'm actually learning too.
It's okay. I like it. Caitlin, in the ACR guidelines, it recommends up titrating to suppress acid level. Yeah.
I was just responding to a
Yep.
question, an earlier question.
Okay. Well, if someone was and is willing to share, let me know, because I'm just curious about how much these move the bar at all.
I didn't change my mind.
Okay.
But I did feel like I had an appreciation for like there is some like I feel like there is enough ambiguity in the area where if a patient was really pushing to have their uric acid tested, I wouldn't be holding on to my I wouldn't hold on to my like we should not test as hard as I probably would have
You're
prior.
holding on to those uric acid chits so tightly that you don't want to
Yeah,
give them up.
I'd probably just be like, sure, we can do that. Like, like I like don't
Good.
care that much.
No, I like that. I like that.
But that's just me.
Yeah. The American College of Rheumatology paper does throw a little throwaway sentence there about, oh, it might be helpful to check on adherence, right? The ACP paper also picks that apart and says, actually, there's no data that it impacts adherence, but that was an idea that was thrown out there that like maybe there's a way to look into whether people are actually taking their medicines as one benefit for that. Okay. So since each of you read only half the guidelines, I'll just put the text of them on here so that you see what we're talking about. So the 2012 ACR, the American College of Rheumatology guidelines, said, and the task force panel, and we'll talk about what that means, recommended regular monitoring every 2 to 5 weeks during initial titration of allopurinol, including continued measurements once the target was achieved. So they're saying every 6 months. seems kind of frequent. I don't check that every 6 months, but maybe I should be based on this recommendation. And they said that the goal is to get to a target of under 6 in all gout case scenarios. They go on to say that even lower for people with tophaceous gout or chronic kidney disease, and to upwardly titrate the allopurinol in order to get to that maximum dose to treat the uric acid level. There's some debate in the chat about whether it's level A or evidence level C and all that sort of stuff, but here's what they present. Okay. So what about, for those of you who read this, what about the ACP guidelines? The ACP guidelines 2017 said evidence was insufficient to conclude whether the benefits of escalating it, in other words, a treat to target strategy, outweigh the harms associated with repeated monitoring and medication escalation. To which the ACR came back to them and said, well, you know, you don't have any studies on that either, if you're saying that there's harms associated. And they said, although observational studies showed an association with lower uric acid levels, so they conceded that, yeah, observational studies, cohort studies, follow-up studies have shown that those that had lower levels actually had fewer flares. But their evidence, what they interpreted was that there's actually not a study that actively checked that out. And so thus they gave it sort of an uncertain, and they couldn't recommend it, was what they said. I wonder if they're more conservative because they just see more weird cases. Yeah. Oh, Lily, hold on to that thought, because your point of view, that old line about where you stand depends on where you sit, or where you sit depends on where you stand, or something like that. Your viewpoint matters in your background and how you think about this. Okay. We're going to take a break. I want to take a break for 15 minutes, give you guys a nice, good break. But during the break, I want you to think about the oyster. And some of you, many of you have probably heard me talk about oysters and how this relates to systematic reviews. And my reminder about the oyster is that oysters are filter feeders, and filter feeders take a lot of stuff and concentrate it into their body. And so it's my representation of thinking about how good stuff that goes into an oyster helps concentrate a delicious oyster, if you happen to like oysters. But they also filter feed, so a little bit of toxins become a lot of toxins concentrated, and so garbage in, garbage out. And so a systematic review is only as good as the information that goes in there. And so again, and I want you to, over the break, think about the oyster, and we'll come back in 15 minutes and regroup at 10:30. Come back. Thank you for indulging my fascination with oysters. Let me go back to here. Let's see here, share screen and share portion of screen. Let's do this. Second. Okay. All right. So let's get into sort of the second part here, which is, what are we supposed to do when these guidelines don't agree with one another, right? I mean, so here we have a situation where two guidelines looking at essentially the same data, because, you know, there's always a possibility between 2012 to 2017 that there's some new really important study that really answered this, and that's why the guidelines look different. But no, actually they're looking at the same data. What do we do? What are we supposed to make of it when clinical guidelines disagree? And in fact, it's not such a rare situation where clinical guidelines disagree, that they say slightly different things. Okay. So again, here are the guidelines that they said here, and the American College of Rheumatology said, yeah, treat to target. American College of Physicians said insufficient data. And by the way, I should say, you should have seen the letters to the editor from the rheumatologist when this came out. They talk about people just up in arms, all sorts of angry letters. And in fact, there's an editorial that accompanied this recommendation from a couple of rheumatologists said, you're out of your mind. We can't believe that you came to this recommendation. Of course, it makes sense to treat to target, was their message. those of you who read the 2012 guidelines, this should sound familiar, but I'm going to share with the other half the methods that they used. And then we'll contrast that with the way that the ACP did this. And maybe this gives us a little hint about why guidelines can differ. And so one way in which they can differ is that they used a different set of tools or a different set of steps. So the American College of Rheumatology, what they did is they said, we're going to divide the work into two groups. We have this clinical expert panel, and the expert panel will do the systematic literature review. We'll develop a report based on that and share that report with the task force group. And we'll create some scenarios. And in these scenarios, we're going to ask people to vote what they would do based upon what we present for the evidence. And we'll ask people to vote. And based on that, we will make a recommendation. So it's a little hard to walk through completely, but let's see if I can try to do that. So the working group, the clinical expert panel was 8 members. It might have been more. It wasn't clear from the list of affiliations, but it looks like the expert panel all consisted of rheumatologists. The task force panel, the second group, was mostly 7 of the 11 were rheumatologists. They also threw a couple of general internal medicine docs. They threw a nephrologist. They threw 1 patient representative in there. And this task force group, what they were responsible for is that they would review the clinical scenarios they were given, and they would then vote on them. And so here's an example of a clinical scenario they were given. This isn't related to our scenario, but this is just an example. They said, for this question, is it appropriate to start allopurinol or other urate lowering therapy during these specified time points? And so they said, you got to vote on it, and you would say, on a scale of 1 through 9, where 9 was definitely always and 1 was never, people would vote on it and said, during the acute attack, would you start allopurinol? During an acute attack, as long as you started colchicine or an NSAID, would you start allopurinol? And then once it was resolved, like after the acute attack had resolved, would you start allopurinol? And so what they did is they did a secret round of voting. And that secret round of voting, they would say on that scale, and then they would discuss. And then they would have an open round of voting. And based on that, that was where they would make the final determination. And so if the average score by the vote from those 11 individuals said yes, with a score of 7 through 9, then that was adopted. They would say, we officially recommend this. Once they figured out which ones were the recommendations, they went back to look at the evidence, the systematic review that they had produced, and assigned the supported recommendation. So they said their level A was if multiple randomized controlled trials or a meta-analysis supported that recommendation, they gave it a level A. They gave it a level B if there was only 1 randomized controlled trial or there was only non-random studies. And level C was expert consensus, which I seem to have misspelled there. So the debate that was going on in the chat a little while ago about like level C, level A, it turns out to be kind of important, right? I mean, level C, they're saying if experts think it's good enough for us, versus level A, that there's actually multiple randomized trials. And so they don't provide for you, like the ACP does, the actual document where they show you the evidence. They're saying this is the process though by which we did this. Yeah, Lauren, the modified Delphi process is this idea of like there's sort of iterative, repeated until they come to consensus kind of process that they're describing there. Okay, so that's how the American College of Rheumatologists did this. They, yeah. How did the ACP do this? So ACP has a very different process by which they do clinical guidelines. So first of all, they don't have a clinical guideline committee that they develop for each specific question. They have a standing clinical guidelines committee. And the standing clinical guidelines committee is based on 12 members that are appointed by the ACP governing board, and they are re-elected every year, and they can serve up to 4 years. And they do it on a rotating basis, so not everyone switches over at the same time. But on this kind of rolling basis, people can serve up to 4 years, but they are on the clinical guidelines committee. During the time in which they're on the clinical guidelines committee, they might get a whole host of different kinds of clinical guidelines. Some might be with gout, some might have to do with cardiology, some might have to do with COVID or something like that. Whatever it is, they're voting on, they're working on what the group has decided that they want to work on. They can farm out to methods people and content experts, but the point of view of ACP in their clinical guidelines is essentially from internists broadly, not necessarily from a subspecialty specific perspective. When they pick a topic, they select the topics that they have a chance to vote on. Yes, we think these are the topics that we want to work on. Then they go back to, among other funding agencies, they go to the federal government and AHRQ for one, and they might go to the federal government and ask to support the research that is necessary to study this clinical guideline, that would inform this clinical guideline. There are other ways in which they do that, but that's probably their most common way in which they're doing this. And so they select predetermined questions. They will then do the systematic review. The committee, the 11 members and the chair, they're voting based on a combination of the strength of the recommendation and the quality of the evidence. They are not doing essentially this sort of series of scenarios like the American College of Rheumatology did, but they are considering these questions a priori created, but with looking directly at the evidence. So in their systematic review for this particular question, I know it's really small on your computer there, and I'm not intending for you to look at it in a whole lot of detail, but like a regular systematic review, they started off with a search strategy. They had a lot of search terms. They narrowed down the 7,900 articles down to 702 articles. Then they reviewed them, and they picked out of those 702 articles, they found 27 of them that related to this question about monitoring and uric acid level. Of those, 9 of them were included for this analysis. The rest of them were things like having to do with, among other things, like traditional Chinese medicine and other studies that they felt weren't directly applicable. So that's how they picked the articles. And then they went through, someone in one of the small groups asked about one of the tables. This is an expanded version of the table. What they are doing on here is it's sort of a grid where they're looking on the one axis of the strength of the recommendation. In other words, like there's a lot of high quality evidence, there's moderate evidence, there's lower evidence, against also the benefits on the other axis, considering the benefits to the individual, benefits to society, and the risks associated. Once they've done that, once they've created the grid, then they have sort of a series of interpretations based on that grid, and they say, based on this, we would put this into the strong recommendation, we put it into the weak recommendation, or we put it into the insufficient evidence. They then, with this information on these questions, then they vote. So the 11 members vote, and when 2/3 of them agree, then it's adopted. That recommendation then goes to the ACP governing board for approval. They post it on a public website, and they invite public comment, and then they finally, based on that, publish it in the Annals of Internal Medicine. The ACP Guidelines Committee has as a policy, they say that if we don't officially update something, our sunset date for all our guidelines is 5 years. So based on that, they haven't done an update on this gout guideline. So the 2017 gout guidelines are technically out of date. And so They're considered no longer official for ACP's purposes. So hopefully that gives you a little glance as to some differences in the way the two groups are doing. They're both taking data, they're both taking interpretations of data, they're both approaching it systematically. How they go about actually calling something good enough to include in their recommendations does differ between the groups. And the makeup of the groups are, in fact, pretty different. They're very different sort of sets of people who are looking at these data. So I'm gonna pause there for a second and ask if there are questions about how these two sets of guidelines were produced, or if people want to share, like if they have immediate reactions or thoughts about it. Anything? Those of you who are reading your papers, I hope that you got at least a little hint of what we're talking about here. One of the small groups was, I think, talking about conflicts of interest and how those were revealed. We're going to talk a little more about conflicts of interest, but it does sound like they were sometimes a little hard to find in at least one of the small groups. So also, I think, important to think about how they handle conflicts of interest. Did either explain mechanism updates based on new data? So Adrian, to your so that's to the question that's in the checklist of, like, was there a mechanism explained there? I don't, other than the ACP group saying if we don't have it, we officially sunset things. I don't think that they explicitly said how they're going to handle it. Jordan, my point isn't to say that subspecialist recommendations are bad or good. We'll talk about what that means, but I think, again, I just want us to be aware of it as we talk about it, and what those points of view bring to the table as well. So if we go back to this idea of this hierarchy of evidence, again, systematic reviews are at the top of this in sort of this traditional hierarchy of evidence. Expert opinion is at the bottom, and randomized control trials and such, you have this hierarchy. Where would we place, how would we place a clinical practice guideline in this? Because there is expert opinion thrown in here, right? I just showed you an example in the cardiology example where expert opinion, in fact, is thrown into there. They do, many clinical practice guidelines do say that there is a role for expert opinion. So if there is this hierarchy, and again, I don't always think that the hierarchy makes always sense, but how would you think about where you would place a clinical practice guideline in this hierarchy? I mean, we treat it as if it's the very top of this pyramid. Does anyone have any reasons to think differently about that, or do we continue to think about them at the top? It depends. Thank you. Exactly right. Any other thoughts? If I teach a session, the answer is always it depends. Will always be an acceptable answer. All right. So again, the example of the oyster. So I said to you that I often think about an oyster or other filter feeders when I'm thinking about a systematic review or meta-analysis, and how it concentrates a lot of data into a small amount of space. I guess the analogy here is more like, you know, if you have a clinical practice guideline, you have the oyster, the systematic review or meta-analysis, but you also have glommed onto it a lot of other stuff that's baked into it. And I don't know, for some of you, this might look delicious. It looks like a lot of stuff onto a small, tiny oyster. And so I think it depends on the clinical practice guideline, the particular group, how much extra layers of expert opinion they're throwing into this. So whether or not that's fits exactly into the hierarchy or not, I only say it to point out that I think that it defies easy representation, and that we shouldn't automatically assume that it belongs at the very, very tip top our supposed hierarchy of evidence, because there's a lot that goes into it, and some are good and some are bad. Again, this example of goal-directed medical therapy for heart failure, just to point out again that part of this recommendation includes this guideline that says, yes, we acknowledge that this is expert opinion that's saying that we need to titrate fast for this. All right. So what is the problem with expert opinion? Why am I giving you a hard time? And to Jordan's point about expert opinion, is it all bad? So, right, like expert opinion is good. We depend on expert opinion all the time. I am constantly, going down the hall and grabbing a rheumatologist to ask their opinion about this strange thing that I'm wondering about. And could you please help me take a look at this joint? So experts we depend on, we want those experts. Topic experts also have this insider knowledge. They know what existing standards of care and practice are. But part of the question, I think, in all of this is it standard of care just because it's always been done that way? Do we know and recognize the blind spots that we have just because we've always done it in training and in practice? And many of you may have heard this famous quote from an industrial person, essentially saying that every system is perfectly designed to get the result it gets. It's been attributed to William Deming, but there's some doubt about whether he was the first one to say this. But this idea that everything looks like the standard of care because that's the way you're trained to do it. And that's the way you've always done it. And sometimes it's hard to look beyond what you've always done to realize that maybe there's something to it not necessarily being the standard of care. There is additionally a lot of entanglement of financial and non-financial conflicts of interest. A lot of subspecialty clinical practice guidelines that contain experts, those experts are oftentimes given honoraria and speakers fees and support for research by pharmaceutical companies or by other groups. And so there are oftentimes financial conflicts of interest that are involved, particularly when dealing with subspecialty driven clinical practice guidelines. What do I mean by non-financial conflicts of interest? What is a non-financial conflict of interest? And so yeah, a financial one is relatively easy, right? Like if you make money, or if there's a potential of making money on it, that is usually pretty straightforward. But sometimes there's more entanglement from these non-financial conflicts of interest. And so some example of this, like you might have a person who is passionate about a topic and is active in an advocacy group that ultimately might benefit from a change in clinical practice guidelines to be recommending something that advocacy group really wants. You might consult for an educational company, and I use just as an example, like UpToDate, or might serve on an editorial board that ultimately might pick whether to publish your guideline or not. And then finally, one thing to also highlight, and I think this is probably the one that impacts most frequently these clinical practice guidelines, is this idea of intellectual conflicts of interest. And this idea of an intellectual conflict of interest, I think, is gaining greater and greater traction as people talk about the pros and cons of clinical practice guidelines. So let's just share, though, some examples of conflicting guidelines. I'm sorry the print is very small here, but let's take, for instance, the U.S. Preventive Services Task Force and the American College of is a Council of Obstetrics and Gynecology, ACOG, so the obstetricians. So conflicting guidelines, I'll summarize the idea of whether to start mammography for women in the 40s based on 2016 guidelines from the U.S. Preventive Services Task Force. They essentially said that it needs to be an individual shared decision-making conversation, that there are, it's not a clear slam dunk in terms of the data, so we give it a level C of evidence. Versus ACOG, which was very firm about it, said, no, women should be offered screening mammograms starting at age 40. And they gave it a level A evidence. Other examples of conflicting guidelines by different groups. So the ACP in 2018 said, when they reviewed this, they said most people with type 2 diabetes should have an informed conversation, but clinicians should target an A1C of between 7 to 8% in most people. Versus the American Association of Clinical Endocrinologists, as you might expect, in their 2017 guidelines said, in general, the goal of therapy should be an A1C of 6.5 or less for non-pregnant adults, if this can be achieved safely. Two groups, right? Two very smart groups, one much more aggressive about its goals. And I think if you think about who they represent, you can imagine that there is maybe a, this is what I mean by intellectual conflict of interest. There might be actually a different perspective depending on the kind of practice you have, the kind of subspecialty patients that you're taking care of, versus if you're doing mostly primary care. Sorry, Ruth, I didn't have a slide of that example. Yeah.
Okay, thank you.
All right. Other comments about guidelines here, and just to think about this, when guidelines become standards, all right, so guidelines, if you read the fine print on the ACP guideline, the ACR guideline, they all have a statement saying something to the effect of that these are recommendations and that physicians should have these conversations with the patients, and they're not meant to replace good clinical decision makings. And by its definition, clinical guidelines are meant to reflect, if well done, the most evidence-based care for the average patient. So it doesn't reflect necessarily the shared decision-making that incorporates the values of the patient, that incorporates the values of the provider. So it's meant to be an average. But increasingly, I think you all feel this, and I hope that I don't have to convince you that this is starting to feel like this is the case. Guideline recommendations are increasingly becoming considered standard of care. So people more and more are starting to think about guidelines as standard of care. Again, how many times do you hear people say, you know, GDMT or the guidelines say this, and so we have to do this. And so more and more, not only physicians and other healthcare providers, but people outside of that are starting to look at these as standard of care. Compensation. So what physicians and hospitals and clinics are paid are increasingly being tied to quality metrics. So insurers are starting to pay if you meet certain quality metrics. That might be an A1C level, that might be a number of people who are getting breast cancer screening, whatever those metrics are. Increasingly, these insurers are looking at those things as quality measures. Those quality metrics are oftentimes linked to these practice guidelines. So although they're built around this idea that they're recommendations only, well-informed recommendations, they are carrying a lot greater weight because of the way in which they're being used. Insurance reimbursement and coverage of procedures or therapeutics is also increasingly being connected to these private practice guidelines. I was just on the phone last week arguing for approval of prior authorization, where this person was going through what sounded like a list that probably came from some sort of clinical practice guidelines, because she was going through a checklist and she said, have you done this? Have you done this? Have you done this? And ultimately I was able to get the procedure that I wanted, but I meant to ask, and I should have asked, where those recommendations were coming from, because they sounded a lot like what I knew were there in terms of guidelines. And so I think that this is going to increasingly become an issue. Kristen, do you think the dichotomy of the differences suggests that NIH Institute of General Internal Medicine should be responsible for funding studies related to conditions primarily treated by non-specialists rather than specialists? Yeah. So a couple of comments about your question. So the NIH has a ton of money. The institute that responds to general internal medicine stuff is a very, 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 very small sliver of the NIH budget. It is virtually, it's like a fraction of a percent of their total budget. They have hardly any money. And so if you believe that people vote with their dollars, NIH as a whole doesn't fund a lot of this, and a lot of it still continues to be funded primarily in support of subspecialty areas. I don't mean to be critical, but that's where the research dollars are going. That's where the money is being spent. So that is a truth. AHRQ, the agency that I mentioned earlier, is actually separate outside of NIH budget, and they're constantly in threat of being shut down, and they're oftentimes running out of money because they do a lot of health services work. They do a lot of stuff doing quality. They're considered lower in priority to the glamorous stuff like curing cancer and ending heart disease and those sort of things.
Thank you.
Yeah, but I do think this is the debate that I want you to have as you pick up these guidelines. What do I think about where the person sits and what's their point of view? And is this influence in these two guidelines about rheumatologists versus mostly generalists? What do I think about that? You know, the fact that a bunch of rheumatologists are really mad that a bunch of generalists say maybe we don't need to check this as often. You know, so I think it really lays bare some of the tension that you're getting at in terms of the point of view of the specialist and point of view of the generalist, and both could be right, and they just are representing different points of view. All right.
Thank you.
So with all of that, how should we use the guidelines? I mean, what do we do with all this stuff? Because, you know, if the answer is always it depends, that's not very satisfying. And what do we actually do with that? So I hinted at this before. There are actually guidelines now about guidelines, which sounds incredibly meta and very layered and just ridiculous, but it is true. ACP, the clinical guidelines committee that I mentioned, also does something called clinical guidance statements, which is a systematic review of existing clinical guidelines. So they take questions that multiple clinical guidelines exist, and they actually sort of go through them with a fine-tooth comb. They've got a longer checklist than what I provided you, and they're going through and sort of like point by point checking to see whether or not they're following what they would consider high quality rules for that guideline. And then based on that, they will then give sort of a summary statement that says, as we look at these guidelines and as we consider which ones are the highest quality, here's our takeaway for this. So that's one where, again, you have to take into account that ACP, again, has a particular point of view and is more of a generalist perspective. But if you wanted to start somewhere and were overwhelmed by like seemingly multiple competing and contradictory guidelines, that's not a bad place to start. The caveat is that they haven't done it for a lot of things, but if there exists one of these meta statements, these guidance statements from ACP, you might start there as a place to look. Okay. But I'm going to share with you the way I think about this, and none of this is evidence-based. I'm just going to give you my thoughts, and I totally welcome all of your thoughts about how you might think about using guidelines. So the guidelines, with all the good and the bad, are here to stay. Let's just start there. They're multiplying, they're exponentially growing. They are rising at a rate that's hard to keep up with. They're not going away. I'll also add, just as a parenthetical, I think that guidelines also serve to elevate the group that they're coming from, right? IDSA having these guidelines about it, it's not just that they're putting out something that is really good for its constituencies, but they also bring attention to IDSA as an organization and help drive membership and help drive participation in a group like IDSA. And so groups, particularly smaller ones, look around and say, you know, we need to get a guideline out. Maybe they say it consciously, maybe they don't, but that also helps their membership and helps drive their participation in their organization. So guidelines are here to stay and are not going away. I would suggest trying to move away, and I'm going to try to do this myself, I'm not always good about this, to avoid language that says the guidelines say, or by the guidelines, we need to do this, because guidelines don't speak. The guidelines are a set of recommendations. I want to give you agency back and say that you get to make the decision together with your patient. You don't robotically have to do the guidelines. Instead, I'd invite you to use language like IDSA and their tuberculosis guidelines recommend, or I reviewed the US Preventive Service Task Force and the ACOG guidelines, and I'm going to recommend to my patient. So don't make the guidelines the active voice in your decision making, is what I'm saying. Don't just accept that they are de facto standards of care. Think of them as what they're intended, which is an informed set of recommendations. Understand that most of them will overlay some degree of expert opinion on top of a systematic review. Whether it's visible or invisible, there is this hand that's pushing the guidelines. The more you know about the group, the more you know about the organization, you can try to get a sense for which direction they are pushing those recommendations, and knowing that is helpful. If you have a chance to, it's not always possible in a busy day, try to skim through the methods a little bit. The who that's involved and the how they're constructed can make actually a big difference in the degree of the opinion. And we give you one example here with the gout guidelines, and saying they can end up with what seem to be totally opposite directions. Some more parts of sort of this modest proposals, also still not evidence-based. There's a lot of checklists. I gave you a checklist. You're welcome to take it, use it however you want to. But a few high quality things to think about as you go through the details, if you happen to read them a little more closely. Look at when the guidelines were issued. Is there new data? Are the guidelines really old and maybe no longer up to date? Who is on the panel? Are they mostly subspecialists? Are they mostly generalists? Are there others? And what direction will those people pull those guidelines if they're going to pull them in a direction? How does the group elevate their review up to a formal recommendation? You know, what do they mean when they say that this evidence is strong enough and clear enough? And then finally, most importantly, ultimately, how can this inform the shared decision that I'm going to have with my patient? All right. I'm going to stop there and just ask for comments and questions. We covered a lot. You read through a big, huge article, at least one of them. What are your thoughts? What are your reactions? Anyone want to change their vote based on what we talked about here? We could run the poll again, but I don't think we need to. Anyone have any thoughts about how they're going to approach guidelines now going forward? Stop the share there. Thoughts? Is everyone sort of despairing that we'll ever get to know anything now? I hope you don't walk away with that opinion.
I'm a little depressed by this. It's like, oh my God.
No, I think again, guidelines are really, really useful. I mean, if you think about some of these questions are so complex, you truly don't have time to go through it all, right? Like I trust IDSA, honestly. I trust the cardiologists. I trust these people who are very, very involved. I just want to know what else to get out of it. And I want to know a little more about, you know, what are they calling good and what are they calling bad before I blindly follow them. So I'm going to try this hard. I have now committed to trying to avoid that language of like the guidelines say, or the guidelines are making me, and those sort of things. How do you include publication bias in your decision, knowing that many negative studies are not published? So Ruth, there are ways in which a good systematic review can address, look for questions about publication bias. Some of you may have heard me talk about something called a funnel plot. There are other sort of semi-quantitative and qualitative ways in which they can look for this. I would say the majority of groups don't do that stuff. I think publication bias is a real danger to this sort of thing, particularly if expert opinion gets layered on top of it, right? Like if positive studies are more likely to see the light of day than negative studies. Plus you add on top of that the layer that a bunch of experts are saying, well, this is the way we always do it, and this is the way we think it should be, then I do worry. And I think that if the guideline correctly identifies this is mostly expert opinion, there's not a whole lot of data, then you are armed with that. But I think sometimes it's hard to see that level of detail when you're just reading the guideline quickly.
And I had a question on, or your thoughts on, like just the likelihood of like really high quality randomized controlled trials being even done for certain clinical questions, like this one about like gout serum levels, like versus like GDMT timing. Like I feel I have more confidence that the cardiology question will have the funding for them to conduct a RCT versus like rheumatology. And I'm just wondering, like, while we,
Oh, you're so young to be so cynical. But it's true, right? There's a lot of money in cardiology drugs and certain drugs. There's a lot less money in allopurinol industry, right? Like that sort of thing.
But also,
Yeah,
I have a comment just about that too. Like, I feel like it's not just necessarily like differences between like different specialties, but like the way that resources are allocated within the specialty, right? So like for the case of gout and allopurinol, right? Like for like an academic physician spread out throughout the country and the way funding works, right? Like you're going to basically like having the resources to run a giant clinical randomized controlled trial for gout for like, multi-center, which is what would be sort of like, you would think would be most useful just to get enough different populations is really pricey. And really then like, you don't get to have all these like hypothesis driven R01s that sort of really are, from a rheumatologist perspective, way more exciting to actually do at each of these institutions, despite the fact that like, most generalists are questioning like standard of practice that it sounds like most rheumatologists agree on, which is like sort of fascinating. And also like kind of what was pushing my question forward just about like, do we collaborate as all the rheumatologists to like do these like really big trials to get the answer to these really important questions that really affect large populations of patients versus sort of maybe more like niche diseases that don't have as much wide applicability but are just more fascinating and potentially have more molecular biology and cellular biology to be learned from.
Yeah, it's not an accident that the greatest growth in terms of dollars has been in biologics, right? I mean, there's a lot of pressures and a lot of pull and push both for people to get sort of personalized medicine, as it were. And in some ways, this is sort of the anti-personalized medicine idea, like you're doing clinical guidelines to get at the average. I think it's worth pointing out a couple of other points that I forgot to make. One is that allopurinol is not entirely benign, right? And they kind of hint at some of that, right? Like in the sense of like, if you come from certain ethnic groups, Han Chinese and Korean and Thai, that there is a higher than average risk of Stevens-Johnson and other things. And so, if you read the letters to the editor and the comments by the rheumatologists, they're kind of like, well, it's not a big deal to monitor, just keep doing it and all this sort of stuff. But again, on a population-wide basis, Stevens-Johnson is not fun, right? It sucks. It's bad. And so this is, it's not an entirely benign issue. Also, in full disclosure, I went back to look to see since 2017, what else has come out on this very question. And in fact, there was a small study done in England. The fact that it wasn't done in the US kind of speaks to Chris and your point, where they actually did a kind of treat to target strategy involving nurses that were sort of empowered to make adjustments on allopurinol based on that. And they in fact found lower rates in this small trial. Now, it wasn't powered particularly well. There's a lot of confounding and all that sorts of stuff. But actually, since 2017, there's a little bit of data that might support that 2012 recommendation. So the 2017 response by the rheumatologists at that point in time wasn't actually factually based on new evidence, but since then there's been the small study that's come out. So maybe we should treat to targets. Everyone should get Lily. Let's not go there. We don't need to make gout more expensive. Yeah, the dermatologists don't like allopurinol. Allopurinol, man, there's some really bad cases of Stevens-Johnson. It only takes one bad Stevens-Johnson's case to really scar you. It's bad.
Yeah, I saw one recently, and I'm truly scarred about using that medication ever
Yeah,
again.
that and certain seizure medications. There's some bad drugs out there. Well, thank you all for participating. I hope you learned something. And Kim, I'm sorry if I made you despondent and despairing of ever using clinical guidelines. That's not my point. I just want us to be a little more critical and a little less accepting them at complete face value. And if I made you a better consumer, that's all I could hope for. All right. With that, we'll let you go early.
Thanks,
Thanks,
everybody.
everyone.
That was awesome.